So I'm James Lewis. I'm at the West Virginia University Health Science Center, and today I'm going to be talking about localization of functions. Dr. Devine here invited me to give a talk about some of the backdrop behind what we know about the function of cortex. And we're going to have thanks to an unknown Neolithic doctor who invented trephining, Phineas Gage, who taught us some things about how cortex functions if it's lesioned, and Walter Friedman we'll talk about a little bit at the end, who inventor of the frontal lobotomy, for better or worse. All right, so what I was objectives was trying to do is taking this from a first-year medical student course in neuroscience and human behavior, and just kind of getting some introductory level input. I'm going to stop share for just a moment and ask a question. How many of you are first year or have not yet had a basic neuroscience curriculum yet? Just show of hands in the raise hand feature. We got 1, 2, 3, a couple have not yet had, okay. And how many of you are second, or how many of you already had neuroscience but are trying to refresh before step exam? Getting a few more hands on that one. Okay, good. There's always a step exam coming up, so I knew that one would get some answers. All right, so I'm going to try to cater this talk for M1 through M4. Some of this will be new to you, but I'll be kind of zipping through that, and you'll be like, oh, this is what I get to learn when I get to neuroscience. And others of you will be like, oh yeah, I learned that years ago, and may need some refresher. But I want to encourage questions as we go throughout this. Okay, back to share screen. So what I was going to try to accomplish in the next 45 minutes or so is to identify some common locations of primary and secondary sensory motor cortices. And we're going to touch briefly on motor, touch, balance, vision, hearing, taste, smell. And then second, describe some general functions of cortical lobes and the anatomical subdivisions therein. Then recognize or predict deficits that are going to result from cortical pathologies, relate this back to blood supply and the like. And now Dr. Jitani already covered some of the methods for studying, assessing, and treating the brain. I had a few slides there. If you're interested, I can go into those a little more, but I was going to skip that in the interest of time. Now for the talk, we typically run through this book through Elsevier. Nolte's Human Brain is where many of the figures that are coming from. And we also use Dwayne Haynes' Neuroanatomy Atlas. It's sort of the Bible for learning the neuroanatomy, underlying brainstem pathways and all those good things. So a lot of what I'm talking about are going to be coming from resources such as those. All right, and just as a background as to who I am, so well, my PhD research involved neurosurgery techniques with macaque monkeys to map out different pathways, especially with parietal cortex. And then I moved on to humans, where I don't cut them open anymore, but now I use functional magnetic resonance imaging. And here's a 3 Tesla scanner at our Health Science Center, and also use electroencephalography or an EEG to study brain signals. I study sensory perception, mostly hearing perception, but also multisensory perception, cognitive behaviors, also studying various populations, autism, chronic pain, and opioid use disorders. So kind of applying a bunch of brain mapping techniques to various human health conditions. So that's my background. And if you have questions, do yell out, because I cannot see hands being raised in this current version when I'm sharing the screen, but feel free to holler out. So this talk, we look at the central nervous system, the brain, the cerebrum, and of the cerebral hemispheres, we'll be focusing mostly on cerebral cortex, basal ganglia, hippocampus, thalamus, hypothalamus. Usually reserve those for separate lectures. And so for this talk, we're just going to hit primarily the cortices. And the part A of the talk will be with primary motor cortices, or primary cortices 1 through 7, for which we have some clinical terms affiliated with deficits to these different regions of the brain. such as vertigo with vestibular, optic ataxias, visual agnosias with vision, central deafness with hearing, and so forth. Then in a part 2, we'll go to higher functions and association cortices. We'll talk a little bit more about language systems, as picking up where Dr. Jutani left off, parietal cortices, frontal cortices, and apply to strokes, lesions as we go along the way. And then if we have time, we could talk some more about methods to study and treat the brain. Okay, so now for everyone who's sitting there at home and alone, you can do the following demo, which is to make a fist. So I'm making a fist, right or left hand, doesn't matter. The brain is basically like a boxing glove, like your fist, and your thumb, it's going to be your temporal lobe. Your knuckles are going to be your frontal lobe. Back of your hand is going to be your parietal lobe, and your wrist arm is connecting to your wrist, is where your occipital lobe is going to be located. And then as we go to the mesial surface, the boundary here is going to form the limbus, or a boundary where the cortex ends up there in that corpus callosum, and that is just generally referred to as limbic cortex, limbus meaning edge. There's multiple things going on in there, but that's sort of the big gross level divvying up of the brain. Now you can computationally unfold, inflate, and view cortex. So here's a three-dimensional rendering of a human brain. And I've color-coded in tan the frontal cortices, green the parietal, in salmon, pink, the occipital and the temporal lobe here in blue. As you can see, you can computationally just increase and reveal the deeper lying sulci. And these are going to be common in all humans and in many primates for that matter. So for instance, we talked earlier, in the earlier talk about the central sulcus located here nice centrally in the brain, and the sylvian fissure, deep fissure in here, segmenting the thumb out where we have our temporal lobe. And you can just take that extreme and flatten it, what have you. So the flow of information, the general organization for the brain is going to be from this Luria model, where we have sensation coming in from the eyes, skin, the ears, what have you, going up through relay nuclei in the thalamus, and then thalamus up into primary visual cortices, primary somatosensory, primary auditory cortices, and then from there up into secondary or association cortices, and ultimately all this information is coming together in associations, which give you a unified perception of a single object. So for instance, if you were to click your finger, I can hear the clicking of my finger, I can see the clicking finger, I have a sense of touch to it. This is a single unified event, and I perceive it as such, even though from the sensory perspective, all of that is being conveyed through different sensory channels. Now, the major thing to remember about organization of the brain is that it's a nice division from the sensory systems, mostly in posterior portions, and then we have the motor systems, mostly anterior to the central sulcus. And this is going to be similar to what we saw about the in the brainstem. The alar plate opens, and you have that sulcus limitans. You have motor more medially and sensory more laterally. And here in cortex, we also have a rough division of motor more anteriorly and sensory more on the posterior surface. So for instance, we have at the posterior lobe, primary visual cortex. We have laterally, just inside, deep in that sylvian sulcus, auditory cortex, and along that post-central lobule, the primary sensory cortex for sense of touch. Okay, so in the next series of slides, we're going to hit 1 through 7, motor, somatosensory, vestibular, vision, hearing, taste, and smell as primary cortical systems before we go to associational areas. Any questions to this point? Okay. So we learn in first couple blocks of a neuroscience course that there's all these horrific tracks and pathways coming up the brainstem to get to the cortex, which we're going to bypass, other than to say the peripheral nervous system, touch, pain, temperature, coming up here, for example, into the thalamus. Thalamus is then going to project that information of I'm feeling sensation on my toe to primary somatosensory cortex and also to somatosensory association cortices, and put together, I have the sensation. And there's a crossing here. And then similarly with motor cortices coming back down, you have your primary motor cortex, premotor and supplementary motor areas working together kind of as a trifecta of regions that are then going to send information to say, oh, I'm going to wiggle my toe. And you have these cortical bulbar and cortical spinal tracts that then cross at the pyramids and decussate and cross. So this sets up the point here. This slide is that you have these crossing, so that when you hear about the left side of the brain controls the right side of the body, well, this is where we're talking about various levels of crossing are occurring. And that's important to keep track of from a neurosurgeon perspective. So for instance, here are the pyramids and the pyramidal decussation for motor input. Will be coming down in here. 90% of the fibers are crossing over from the right to the left or vice versa. And that's where that decussation occurs. And similarly, here are those pyramids again, and here's that inferior olive, some neuroanatomy to give you some flashbacks to when you had learned this stuff, or when you're going to be learning this stuff in upcoming years. Okay, with the motor cortices now, high yield concept is to recall that we have somatotopic representations, and in particular we have, if you go with foot, leg, trunk, arm, and hand, here we are in primary motor cortex in the purple. We have leg and foot on the mesial wall, medial surface, trunk, arm, and hand sort of extending out, and then face and mouth extending out laterally and further inferior as you go along that precentral gyrus. Then we have a premotor cortex, which also has roughly a somatotopic map, foot, leg, hand, arm, face, mouth. And then on the superior frontal gyrus, supplementary motor areas, we have leg, arm, face, another somatotopic map. And this is important to relate to if you have, for instance, a stroke that were to take out the ACA, the anterior cerebral artery. Recall that that is going to wrap up along this pericallosal region and have a pericallosal artery and a supramarginal artery, and is going to be supplying the territories that are mostly covering this leg foot region. So if you have a patient who has a deficit with their left leg, you might be thinking right mesial cortex and an ACA type of stroke there. Versus if there's a MCA stroke, middle cerebral artery, that's going to be covering more of this lateral surface. And if everyone puts their hand out like so, if this is going to be the distribution of the middle cerebral artery, if you take your hand out, put the palm of your head just above your ear and wrap it over your head, that is roughly the distribution of the MCA, middle cerebral artery. And so with MCA strokes, as we heard about earlier, you're going to have affecting more the face, hand, arm type of regions rather than the lower limbs. And that's evident based on this rough topography of the brain. Okay, so the motor cortices. More specifically, we have a new color scheme now, but we have the motor cortex, we have the central sulcus, indicated if you can see my cursor moving. The red colored cortex is along the precentral, which is where our primary motor cortex is located. Anterior to that is our premotor cortex, and then superior and mesial to that, supplementary motor areas. Now these areas, I'll discuss them each sort of individually, but think of them as kind of working together. But if you go back to Dr. Jutani's lab and she were to open up your skull and put some electrodes in there and stimulate, we're going to find that stimulation is going to elicit in a awake behaving patient a non-preventable discrete motor movement of one or small group of muscles. So if I were to stimulate in my right motor cortex right over the hand region, zap, stimulate my hand, zap, stimulate. I'm going to say, okay, don't move my finger, zap, can't prevent it. It's not preventable. And it's crossing, so right side again, controlling the left side of the body. And all the movements are contralateral except for tongue, masseter, pharynx, and some of the oral features and muscles. Now, lesions to primary motor cortex initially will lead to a flaccid paralysis, but then it's going to resolve quickly to hemiparesis, mild spasticity. And you're going to have most evident problems with fine, skilled movements. Now, one of the interesting things that Dr. Jackson here back in the 1900s discovered is you can have individuals with seizures where a seizure may initiate, say, at the finger on the left hand, and the seizure would start to cause the body to move, and it would propagate up to the arm, and the arm would go to the upper arm, and then to the neck, trunk region, and then might actually cross over to the other side of the body, and it goes along this nice somatotopic map. And that was one of the first clues that we had that there is a somatotopic organization in motor cortex, or mototopic organization in motor cortex. And so that's referred to as a Jacksonian seizure when you see someone who has a seizure where the spread of the epileptic motor spasticity just spreads along a mototopic map like that. And here is the homunculus. I call him Freddy. I think it looks like a Freddy. If you were to take the amount of cortical real estate that is devoted to the various parts of the body, you've got enormous representation of the tongue, enormous representation of the hands, because as we creatures are very much about using our hands. And you can see the trunk and so forth is much less relative amount of cortical real estate devoted to control of motor movements in that regard. So that's our motor homunculus. Then in premotor cortex, in the blue area up in here, you can stimulate up in here. Thresholds are higher to get a movement, but the movements are slower, larger groups of muscles involved. If you lesion, no paralysis or reflex changes unless you also take out some of the primary motor cortex. And if you take out both premotor and motor cortices, you can get then the full-blown spastic hemiparesis. And then so in general, the premotor cortex is thought to be important for movements guided by external stimuli. So if I want to reach out and grab my pen, let's go ahead and initiate that movement. Boom, I go and do that. These areas are required for that initiation. The third area, the supplementary motor area, SMA, mostly in the purplish color here and on the mesial surface. Here's our paracentral lobule, for instance. And stimulation in these regions are going, in the red, sorry, up in here. Stimulation is going to cause assumption of posture, so stimulate, and you might have a full trunk type of movement, turning the head and the trunk. Sometimes you can cause vocalizations. You can even lead to speech arrest. So there's some involvement, some more fundamental elements of speech processing here, or speech production rather. And so this is thought to be more involved with the planning and learning of complex intrinsically generated movements. Okay, so here we have a coronal image, a T2, and just looking at some functional landmarks for review here. So in green, we have our central sulcus, and our paracentral lobule is going to be on either side of this, a precentral gyrus depicted between the green and the blue line, and a postcentral gyrus between the green and the red line here. So those are running along the central sulcus, going superior to inferior, and immediately in front of that, our frontal cortices are going to be running more anterior posterior, and here this orange line is delineating, for instance, our superior frontal gyrus from our middle frontal gyrus in an image such as this. Another important feature is the hand hook. So it turns out, so far this is our central sulcus on the right side, and you can see this little omega here. The cortex often in many individuals is going to have an actual shape like this. So you can actually surgically, when you take off the skull plate, you can sometimes see what is going to be this hand hook region. Of course, as Dr. Vitani mentioned, you want to keep that as eloquent cortex as possible, since we are all about using our hands. And this is often an anatomical feature that can be seen visibly. Of course, better is to map it out using functional MRI, but if you don't have that option, here you can see it in many individuals. Okay, somatosensory cortices. Any questions so far? Okay, with the primary somatosensory cortices, we have the thalamus, VPM, VPL, projecting up to Rodman areas 1, 2, and 3 are generally going to be considered primary somatosensory cortex. And these are so depicted in the far right diagram. So if you have input coming in, touch to your finger, you have a sense of touch coming up in the green. It's going to cross at some point, go up to thalamus and onto cortex. And then likewise, your sensation of pain is going to cross right away at the white anterior commissure, go up a separate pathway and go up to cortex. And in primary somatosensory cortex, whether you feel pain or light touch or deep pressure, that primary sensory cortex is saying, oh, here's where I'm feeling it. It's going to localize where that sensation is on your body type. And so the neurons up in here are going to have sensitivity to light touch. And as you get to areas 1 and 2, then you get a little bit more association going on, and you have more complex receptive fields, such as the limb's position and the shape of an object. When you're touching with your skin, you can determine some shape, features, and so forth as you go from 3 to 1 to 2. Then primary somatosensory cortex, if you stimulate that with an electrode, I tend to get a tingling or numbness in that contralateral part of the body. So we stimulate on the right side somatosensory cortex. I'll feel like a tingling sensation over here in my left hand somewhere. Rarely feel pain, and sometimes you can elicit a little bit of movements. If you have a lesion here, larger lesions, you can impair finer aspects of sensory sensation. It's hard to tell exactly where in what space you're being stimulated. Deficit in your sense of position and movement of affected parts, but does not abolish your tactile sensation of pain or for pain. So in general, S1, good for localizing pain or touch, but if you want to say the unpleasantness quality of pain, that tends to be other cortical areas. It's more widely distributed throughout the brain. Pain's more difficult to deal with. Okay. Oh, and with regard to S2 on our second slide here, so our secondary somatosensory cortices, mostly located up here along the parietal operculum. Operculum just means lid. Here's the parietal cortex, and here's the lid overlying that sylvian fissure, parietal operculum. And it too has a somatotopic map. So in the lower right diagram, again, we had with S1, we had the lower limb on the mesial surface, then thorax, neck, shoulder, hand. Here we have fingers, and then we go to tongue, and the face is out here. And then with S2, it goes the other direction, face to arm to leg as you go back lateral to medial up into that parietal operculum. So it too has a somatotopic map. And the receptive fields in here, if you go with an electrode and try to map that out in a person, is going to be more bilateral, touch to symmetrical places, sites to activate them, say on both of your index fingers. And with this fun demo, for those of you who happen to have some coins in your pockets, I have here various coins, and you can try this with a friend at home, or if you're with someone in the room there, is to put a coin in your hand. I'm going to put this one right here in my hand, and without looking, tactile feel, what is that coin? Is that a nickel? No. Is that a silver dollar? No, I don't think so. Quarter. I can figure out what that is. And that's using stereognosis, where you are grasping the coin, tactile, palpating it, putting together what is that three-dimensional object. And with lesions that take out S2, you can then lead to astereognosis, or that inability to identify what is this object based on sense of touch. All right, so a question comes up as to why on earth does this, here we have the homunculi, Milton and Freddie here, the somatosensory cortex and the motor cortex models. A question often comes up, why does it go leg to foot to hand and right next to face? Because I mean, your face and your hand are pretty darn far apart anatomically. So I'm going to stop sharing screen for just a moment. Thought question. Why is the hand representation near the face representation in cortex? I'll pick on someone who's got their screen on. Sure. Noor, why on earth is the hand representation near the face representation in cortex in us humans? Or Carly?
I'm not 100% certain, but it might have something to do with the development or embryological origin, maybe, of how the
I like it.
Development works. I'm not sure.
Yeah, no, that's a good answer. That is a very good answer. Alexander, Kalina, Carly, any other thoughts as to elaborate on Noor's idea there? I mean, if you were designing a brain yourself, were you going to stick the hand next to the face? I mean, why wouldn't you got your hand out here, your foot way out here? I mean, how on Cortex, why is this somatotopic map like this?
Could it be that they're like super like high acuity and like very high sensation? So you want to put the things that have very high or distinct senses next to each other versus like the leg where it's not as sensory?
That's also a good answer. Yeah, I think that's going to be part of it too. I think that's going to be part of it too. All right, so I'm going to show you a 2-minute video here where I think we can put together behaviorally at least why it might be important. I mean, the answer is not entirely known, obviously. This is more of a thought question, but let me share a screen to this short video.
Wait, Dr. Lewis.
Oh, yes.
Just a quick thing adding on to there and Nora was saying. So is also related to the fact of like eating essentially and how that stuff is important. Like you need
That's
your
what I'm
hands
thinking
to feel
too.
food and like your mouth to taste and like to feel.
Yep. So Marquis, I'm going to show you this video and see what you think if this answers. And I think all of you touched on correct answers there. And let's listen to this one. Make sure I can share sound. Okay. Divine holler if you don't hear the audio on this one. It should work, but let me try it. Okay, are you seeing that?
Yeah.
Okay.
Rend the homunculus, take 4. Here we are at the COVID-19 pandemic makeshift at-home neuroscience and human behavior laboratory. In this demonstration, we are going to see a participant, a young Homo sapiens sapien child, using her fingers and lips during feeding behavior. And I want you to take particular attention on her fingers, hand, and mouth, lips representation as we engage in feeding behaviors. Here it is. Banana. Good for you food, unlike cookies. We're going to try now with the gummy bear. And you're watching the fingers and mouth as she is placing her fingers up to her mouth as she grabs the food item, palpates it, knows what that object is, and her mouth and hands both have high density of receptors. This is the most information per unit time, and so it kind of makes sense that the hand and mouth representations are close to one another in the brain for efficiency of wiring, so you can get more processing quickly to engage in feeding behaviors, which are critical for survival for our species and primates who eat with their hands. Say, hi medical students!
I'm gonna do it!
Cerebral peduncle?
No.
Oh.
Okay.
That was great.
Did that clarify a possible answer? So Marquis, is that what you're going after?
Yeah.
Yep. Yep. So that's interesting to think about, especially when you're talking about the eloquent cortex that Dr. Tutani was mentioning about what circuits are working together and which are close together nearby, which is of interest surgically, since we are talking ballpark, grape size, golf ball size chunks of cortex that one's generally dealing with pathologies that we can attend to. Okay, so back to the slides. Are there any other thoughts, questions at this time? Hold on a second. I think I got that wrong. Share screen. Okay, so that was our toddler demo eating mnemonic to memorize why the face and hand representations are probably close together in cortex. Important for our species to be able to eat. So with somatosensory cortices, there are some interesting things such as Lord Nelson back in late 1700s lost his arm during a battle, but could still feel the sensation in his arm. What? How's that possible? Proof of existence of a soul, he thought. And then we had people, let's see, Dr. Mitchell, back in the American Civil War, we had more individuals surviving gunshot wounds to the head and, gunshot wounds to various limbs. The limbs would be amputated, and we had hundreds of cases of people with phantom limb, which is, and Dr. Mitchell coined the term phantom limb. And oftentimes you're going to have a sense of illusion that the limb is still there. Oftentimes it's painful. How do you treat a painful limb that's not there? And here is someone came to my lab a few years back, Catherine Baumkamp, and she was working on some prosthetics, like a heat type prosthetic that supplies heat to the edge here as one method to help with phantom limb type pain. It's also as an article in Glamour magazine too. Anyway, that's the side note. Okay, so going now from motor and sensory motor cortexes to vestibular cortex, going down the line here of different senses. There's no single vestibular cortex per se. I mean, you have a vestibular cochlear nerve affiliated with cranial nerve 8, the vestibular portion of the vestibular cochlear nerve. And that is going to go send projections in posterior insula and parietal lobe. And here you have regions that are activated with caloric stimulation, showing brain regions that are involved with that sense of vestibulation. And it makes sense that it's near the face region in S1, S2-ish kind of land out in here. Now, an interesting point clinically from this is dizzy patients. And oftentimes you can have issues with semicircular canals or the nerve, and that can lead to dizziness. That's straightforward, but sometimes you can have responses to medications and have no peripheral issues with the vestibular system, yet the person is dizzy. Well, how the heck is that going on? What's going on with that? And we had a study here, a physician a few years ago, looking at areas of the brain giving us that sensation of vertigo and dizziness, even from a central type of disorder. That's vestibular cortex. Visual cortex. Okay, so again, when we make a fist, the occipital cortex is going to be where your arm is connecting into your wrist on the very back end here. And on the medial surface, we're going to have this calcarine sulcus, or it's a hook-like sulcus, separating a superior and inferior lobe. We have the cuneus, the cuneate lobe, and the lingual gyrus, this more inferior aspect. And in this image, we can again inflate and expand. So visual cortex is going to be located here. We have in color various retinotopically mapped areas of the brain on average from about 20 or 30 subjects. And as we inflate and unfold that, we can see the occipital lobe, multiple distinct visual areas. Each one of these colored areas of cortex has a visual topic map from central out to periphery, map of the visual field, of one hemivisual field, as we'll see in a moment. But point to mark here is there's our calcarine sulcus, primary visual cortex in the purple here is where this is located. We've got areas for motion processing and a multitude of other areas. That's 2 more lectures of material on that one. But there's our visual cortex. One last piece I'll put onto there is, as a review, you have to remember after the optic chiasm, we had our optic nerves come to the optic chiasm, about half the retinal ganglion fibers cross, so that we have going into this lateral geniculate nucleus, you've got all the input from the left nasal retina side is going to be looking at your left visual space, goes to the right side of your brain. And in your right eye, that temporal retina, which is also conveying the left visual field, is going to the right side. So everything in the right side of your vision, of where if you're looking straight ahead, and if I put up my fingers here, how many fingers do you see? That is in your, I'm assuming your right visual field, that is going to your left occipital cortex for conscious level perception of what you are seeing there. And so that is occurring at the cross, the optic chiasm. So once we get behind the optic chiasm here in the optic tract, you have a hemifield representation. The contralateral hemifield is represented here, going to the LGN, lateral geniculate nucleus. And to memorize LGN from MGN, L is for light LGN, M is for music or sound. Sound processing is more your medial geniculate nucleus. LGN is light, lateral geniculate nucleus. Okay. And then we have our optic radiations that would be coming back here to the calcarine sulcus and these other visual areas. And these inputs are all retinotopically organized or visuotopically organized. So you can have lesions back in here, taking out Meyer's loop or optic radiations, and you can tell or predict what kind of visual field deficits a patient's going to have. Won't go into those details, just to remind you that those are kind of high yield concepts that come up on STEP exams. Bigger picture level, what's going in the visual cortex, then we start thinking about streams and major pathways. So as you go dorsally directed from, say, these magnocellular layers in the LGN to various areas of cortex to more parietal superior regions are going to be involved with your perception of motion and location. Where are things in space? So if you have to reach out and grab your beverage, where is it in space? Then you have information flowing along the infratemporal cortices, and these are going to be more about, well, what is that? Is it, what color is that cup? Is it blue? Is it red? What is the shape, if you had to state what the shape is? And so the information of form, or what is it, is going to be going down toward vision for perception, towards these infratemporal regions of the brain. So the gross level object for action going dorsal, and the object for what is it for perception going more ventrally. Then interestingly, with carbon monoxide poisoning, it's not terribly uncommon to have what's called a condition called blind sight. For whatever reasons, this region's cortex more sensitive to carbon monoxide poisoning. And if you take out both the left and right occipital cortices along the calcar and sulci, for instance, you lose your perception of what you are seeing. However, conscious level perception. However, you can still, quote unquote, see and have more reflexive level of vision. So for instance, here's a patient with blind sight who's, and the doctor's here, okay, what is the orientation of this bar on the TV screen? And they're like, well, consciously, I can't see anything. Well, just make a guess. All right, horizontal. Like what? So that information is getting through to the brain in other areas, but not at a conscious level of perception. And so this and other lesions like that give us some more clues to understanding how vision works in the human brain. Still don't fully understand it, obviously, but there's some fascinating knowledge about different pathways and routes of information flow. And there are numerous other type of visual lesions, prosopagnosia, achromatopsias, and so forth, which again is a topic of another lecture.
Dr. Lewis, is that
Yeah.
a permanent change that happens with the blind side, or does that heal over time?
My understanding is that's permanent. If it's, yeah, my guess is permanent, but I don't see patients and I don't have a full answer for that. I would imagine you can have a condition where it could be transient, but with the carbon monoxide poisoning, once your neurons die, that's it. The central nervous system, they're not coming back. You're not going to be getting that conscious perception coming back. Any other questions? Okay. Auditory cortex. So you'll recall, here we have our image in the lower left corner. Here's our semicircular canals. Here's our cochlea right next door. And we have this vestibular cochlear nerve coming in here, 7 and 8, going through the internal acoustic meatus, all those good things. Focusing on the cochlea, I think of this as a backward piano keyboard because this has basically a tonotopically organized organization to it. And this information at a tonotopic level is going to go through this auditory nerve, through the vestibular cochlear nerve, into our cochlear nuclei, and from there it's going to bounce around through half a dozen brainstem areas, work its way up through the inferior colliculus, go out that brachium of the inferior colliculus up to the medial geniculate body. Remember, medial for music, MGN, and from the medial geniculate to auditory cortex. And if you take your boxing glove, you make your fist and open that thumb, you're looking inside the sylvian fissure or that lateral sulcus, and in that posterior aspect is a transverse temporal gyrus. And that's where your primary auditory cortex is hanging out. So here's a primary auditory cortex. And you can use functional MRI to map that out. So here are 8 people from my lab where we mapped out tonotopic high to medium to low pitches. And on average, here's where the primary auditory cortex is located. And you can map out areas sensitive to vocalization, shown in the blue, and then areas that are sensitive to speech, native speech for English speakers in this case. And these areas more in the pink become more sensitive when you hear speech-related sounds. So the point of this slide is that as you go from the early tonotopically organized auditory areas to more complex stimuli such as vocalizations and speech sounds, you're going out more laterally and spreading out along the cortical mantle as these more higher association areas put together what does that sound information, put together words for you and other acoustic objects. Now, if you have, and here's to go with Dr. Jutani's talk, here we have a DTI image looking at some of that tractography going from the medial geniculate nucleus out to transverse temporal gyrus with the fusion tensor imaging shown here. If you have a lesion to one of your primary auditory cortex, you may have some difficulty localizing sound, subtle hearing loss, but usually not terribly bad. You really need to take out both the left and right hemisphere. And if you do that, then you lose conscious level perception of what you're hearing. Now, if it's just the cortex that you're taking out, you still have acoustic reflexes intact. So if you hear something and jump and respond to that, that's going through that inferior colliculus and brainstem structures, and those can be still relatively intact. But you're not consciously aware of what you're hearing. Then auditory association cortices, we get to the superior temporal gyrus and superior temporal sulcus region. And when you have damage there, that can lead to what's called central hearing loss. So you might be able to hear that there's a sound, but you may have difficulty putting it together. What are you hearing? And that ties in with what Dr. Tani was talking about with Wernicke's area. If it's a left hemisphere damage, and this would be a Wernicke's area where right is on the, right is on the left side of the screen. It's radiologic format. And if that's affecting your Wernicke's area or your language reception areas, then you have difficulty putting words together. You can hear someone's talking, but you can't tell what they're saying. It's kind of like Charlie Brown, the adults, when they hear the wah, 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 wah. I can tell you're talking, but I don't know what you're saying. That's auditory. Taste, gustation. So just kind of zipping through the rest of our modalities here. And I'll speed up a little bit. Sensation of taste going from the tongue. Remember, cranial nerves 7, 9, and 10 are doing taste. 7, cranial nerve 7, the facial nerve, is going to have that chorda tympani, anterior 2/3 of the tongue, sensation of taste, that salty, bitter, sour, sweet, umami. That's going to work its way up to the solitary nuclei, works its way to the thalamus, then to the superior limiting sulcus of the insula, shown here in area G, gustation. So your primary sense of taste up around in this area. Stimulation up here cause sensation of taste, and seizures sometimes can be precluded by an aura, including a taste sensation. And this was just for those of you who have not yet taken neuroanatomy, it's the myelin stain section on the left and a wet brain on the far right, and a T2 image in the middle here, or a T1 image. And just sort of remind you, you're learning foundational knowledge. You're never going to see your myelin stain section of your patient. So why do you have to learn this stuff? But there's just sort of a plug to remember to learn your neuroanatomy, so all this foundational knowledge makes sense to you. So when you start learning some of the high yield terms, you really need this foundational knowledge to understand where you are in the brain and what these areas are. Okay, sense of smell. So for the olfaction, we have in the lower left, going up through the cribriform plate of the ethmoid bone, sensation going to these 20 or so cranial nerves, go to the olfactory bulb, and then from there, the olfactory bulb goes to the olfactory tract, and that information works its way back to piriform cortex. It's thought sort of to be a primary sense of smell area. But unlike the other senses, smell does not have to go through the thalamus before you can go into the rest of the brain and conscious perception. So it's a different paleocortical type of pathway, more ancient pathway in us humans. So we can have stimulation can cause a sensation of olfactory sensation, and seizures, and this one's important clinically. If you have seizures that have an epicenter that might be in this region of cortex, you can have a seizure initiate with unpleasant smell like burning rubber. So if a patient's like, yeah, I smell this burning rubber, and then I collapse to the floor with some seizure activity, that could be a clue that you might have an epicenter focus in olfactory related cortex. And smell goes to the amygdala, sense of smell. So you have those powerful memories, mom's baking, and can wake you up, heightened alertness. And you can have some really strong associations with memory, like you can smell cookies that like, whoa, that takes me back to when I was 7-year-old in my mom's kitchen smelling those chocolate chip cookies. It has this direct pathway into the cortex, which is thought to convey some of these behaviors for us. Okay, so that was sort of a zip through of primary cortices. And before I go to association cortices and higher functions, and it's not terribly long, let's go back to some question answers so far. Share screen again. Any thoughts, questions at this point?
I have a question about the auditory cortex. Is that does that project contralaterally or ipsilaterally? Because the I think this is the image that you showed. I wasn't necessarily sure.
Right. So the auditory cortex is going to be much more heavily bilateral. So we talk typically about how vision, everything in your right visual field goes to the left side of your brain, and sense of touch, your right hand goes to the left hemisphere, and your motor to move your hand is the left, controls the right side. With the auditory system, it's an older system. There is a left-right bias for sure. So if you take out right auditory cortices, you're going to have more of a deficit in your left auditory field, but there are far more crosses and information flowing at the brainstem level that cross over, that you're going to quickly overcome that deficit. Hearing is so important for us because you got to be able to hear for predators coming in the middle of the night. You can do it with one ear or the other ear, doesn't matter. It's always on. You don't shut your ears. And so I think of it in those terms. It's much more bilaterally represented early on in the brainstem. So you can compensate for injury to a left or a right side only type of an injury. Does that answer that question?
Yes, thank you.
Hello, Doctor. I do have a question. With the issue, I know this is probably digressing a little bit, but a question about the injury could be permanent or maybe not permanent. I've read some brain-computer interface research trying to claim that they want to use VR or AR to restore some function after stroke, so that maybe using that, it could be able to create some neurogenesis or something to restore those functions. Is it a dead end research, or is there prospect out there?
Definitely prospects out there for prosthetics and the like. Yeah, that's another 1 or 2 hours of lecture right there. We have Dr. Suri and Valerie Gritsenko in our WView here are a couple of researchers that look at prosthetics and brain-machine interfacing device. The way I look at it is if you had function such as vision or hearing, and then you lose it, and then you can have a prosthetic to restore it. If it's peripheral, yeah, then you can have a chance at restoring that. If you've never had the sensation from birth, if you've never had vision since birth, the cortex never developed to deal with vision, and so prosthetics aren't going to do you much because you don't have the neural hardware to interpret what's going on there at sort of a fundamental level. So then there's everything in between there, is like, when did you lose vision or your hearing or sense of touch? When do you get the prosthetics, to how much neuroplasticity there is? And then there's the way the brain can alternatively try to deal with the information. For instance, I think some blind people have had input sensors onto their tongue, and they learned to take the tongue stimulation to interpret what was visually coming into a device that would stimulate their tongue, and they could quote unquote see objects based on tactile the tongue. So there's a huge range to answer that question. Yeah, that's a tough question to answer. I'm going to say sure.
All right, thank you.
Good. No, that's a good question, because there's a lot of research out there about prosthetics, vision, hearing, and prosthetic arms and the like, and how do you integrate it with patent nervous system. And yeah, that's a loaded question. A lot of answer to that one.
Yeah, because that really, the concept of permanence, and it still seems to baffle me, because if somebody get exposed to some different experience, or they move from one continent to the other, start getting exposure to stuff, the brain definitely still have to develop a way of forming those consciousness. And is that related to forming new kind of neurons that could be, in the times of evolution, could be perceived as the brain is still growing? Or, I mean, if you don't have it, then even if you get exposed to it, you would not be able to form any neurons. You know what I'm saying? It just always confused me.
Yeah, now we're getting into neurophilosophy here, so that's great. This is the philosophy of how the brain, what are these concepts, what are these perceptions, which I guess is a good segue to the next little part of the talk. Divine, are we going, what, another 8 minutes or so?
Yeah, you can go ahead. I think your last few slides are brief, so we can go ahead.
Okay, I'll try to zip through some of these higher level association concepts, which will only barely touch upon some of these last questions, but at least give us some more fodder to think about. All right, so let me go back to share screen. Okay, so briefly I'll touch on language systems, parietal cortices for spatial neglect, and then frontal cortices and frontal release signs. So here we have the lateral view of the brain, and Dr. Chitani showed an image similar to this earlier. So we have our primary motor cortex and primary sensory cortex, paracentral lobule for orientation. We have our Wernicke's area in green between that parietal temporal occipital junction, and Broca's area for speech production in the left inferior frontal lobule region up in here. And if you want to hear speech, hearing me talk, for instance, the information is coming through these auditory cortex, working its way back to this Wernicke's area, which is more of a conceptual space than anything physically real. And then this information goes along the arcuate fasciculus to Broca's area. And if I wanted to repeat what is being said, Broca's area can send this information to motor cortex. Motor cortex then sends it to all the 100 or so muscles involved with speech production, so that I can then convey words and phrases to you. Now, if I am reading words, the information goes through visual cortex, also works its way to Wernicke's area, so I can read information. And if I can read Braille, tactile information, you can take Braille, and that also works its way through Wernicke's area for language reception. And then Broca's for the production. And as mentioned, in most right-handers, 95 to 98% of the time, these Broca's and Wernicke's is going to be in the left hemisphere, occasionally flips over. And for left-handers out there, it's usually about 75% show strong left lateralization, and then different percentages. It can be either completely flipped to the other hemisphere or more bilaterally represented, and that's when you want to have fMRI and other tasks to try to map that out more specifically for your patient. Here's an image showing the arcuate fasciculus in the left hemisphere. This is most strongly developed in us humans relative to apes and to monkeys. And here is a lesion, for instance, back in Wernicke's. Here we can see there's our thumb from the temporal lobe. Here's our Sylvian fissure, and our middle temporal gyrus, superior temporal gyrus, middle temporal gyrus, and so forth. Just refreshing our anatomy. Here we had from Dr. Broca back in 1800s, a patient who had Broca's area damaged, and in that inferior frontal lobule. And here are areas that are involved with language production in another individual. You can see mostly in that left inferior frontal gyrus region, but you also have with language production some areas of the brain light up with a functional image such as this. So it's more complicated than just these areas, but thinking about Broca's and Wernicke's is a good starting point for thinking about language systems. With aphasias, if you wipe out back in this temporal parietal occipital junction, going to be affiliated with the Wernicke's aphasia, again, up inferior frontal lobule Broca's. If you cut between the two, supramarginal gyrus and that arcuate fasciculus, you can have what's called a conduction aphasia. So what you're hearing doesn't get conveyed over to what you're speaking. And then all of this will be a global aphasia. Here in the lower left is a high yield aphasia square. Make sure you guys memorize that. And basically, if you have good comprehension or poor comprehension, fluent speech or non-fluent speech are the major 2 by 2. And then whether you can repeat or not is going to be important. So if you can say arcuate fasciculus, and then Divine says arcuate fasciculus, then I will know that he had good comprehension and good fluency, and the information could go from the posterior sensory side of things to the motor, anterior motor side of things. And so these are the 4 basic elements for classifying the different forms of aphasia, or inability to use language. And that tends to be lateralized to the left hemisphere, but not always. Here's a cool syndrome to help think about this. Alexia without agraphia. So if you have a lesion to the posterior cerebral artery, taking out, say, the left PCA, if you are the information, that visual cortex, so if you were to write down your name, so if your name was Divine before, you write down D-I-V-I-N-E, great. And now if you wanted to read that, you would have visual cortex back in here, and here would see the words and send the information to Wernicke's area to see what you're reading. But with this particular stroke, the visual input with the PCA lesion here, there's no visual processing. So this area of the brain is not talking to Wernicke's area. And if you took out the splenium of the corpus callosum, the right hemisphere cannot, it can read, but it can't send the information to Wernicke's area. So with this person with this lesion, they could write down their name, but if you ask them to read what they wrote, they would not be able to read it. What? Alexia without agraphia. So syndromes like these, this is called the disconnection syndrome, also give us some clues about the nature of how the human mind works. All right, protocortex in 1 minute or less. So the protocortex is where, again, you're getting information from all the senses, your auditory, visual, somatosensory, coming in here to establish and maintain a sense of spatial relationships of things relative to you in the outside world. And so, for instance, if you were not this drill sergeant here, not this guy who's being tutored, but rather this guy in the red arrow, if he's looking front and center, where is his spatial attention at this time? Do you think his spatial attention's on the wall where he's looking over here? Heck no. His spatial attention is right here on what this drill sergeant is doing to make sure he's not next to be tutored here. And the areas of the brain shown in the green and yellow are part of the spatial attention network. So you got these superior parietal regions and some of this motor cortical regions here. So he is sensing what's out there in space. Where is it in space? Even though he's not looking directly at it, right? It could be separated from where you're looking as to what you're attending to. But this network is critical, this frontal parietal network for spatial attention network, your spotlight of attention. Where are you attending in space, regardless of vision, auditory, or tactile? You can have lesions. Here's a large right lesion leading to called spatial neglect or parietal neglect. So the left parietal lobe represents your right hemifield of space where you're seeing and hearing out there and tactile feeling. Your right parietal cortex is representing, it has left and right, it has a little bit of both representations. It's more dominant for spatial orienting. So if you have right parietal damage, there is no part of your brain that can now deal with the left side of your space. And so someone with right parietal damage will be ignoring the right side of their space. They may fail to shave the left side of their body. They may not dress the left side of their body. They may not eat from the left side of a plate. And these are some classic examples of someone to here draw a clock. They draw the clock, they completely ignore the left side. Draw the picture of this house, they ignore most of the left side of the house. Bisect this line into 2 equal halves, they're way off due to this parietal neglect. And Gerstman Syndrome is what you associate with that. So if you wanted to, okay, everybody put your hand out and scratch your head like this. Good, so you had the willful intent to go and scratch your head. Now, if you had someone with the lesion taking out in the brown here, you may have that lose that ability to send the information, that intent to make that movement to go and scratch your head when I asked you to do that. However, if you had an itch on your head, you might want to just go and scratch it just reflexively. So the motor planning to make that motor movement is intact, but the willful act to intend to and have that happen can be disrupted. Prefrontal cortices in 1 minute or less. Dorsolateral prefrontal cortex involved with working memory, motor planning, organization, and intellectual function. And then we have the ventral medial prefrontal cortices involved also in executive functions and planning, foresight, personality, some elements of intelligence thought to be here. And again, this is where Phineas Gage comes in. He had the tamponing rod shoot up through his eyes, miraculously survived. He used to be a person who was very hardworking, responsible, clever, very respectable individual. And after the accident, taking out ventral medial prefrontal cortex, he became tactless, impulsive, loses money, lost his relationships, not bad with relationships, totally changed the personality. So again, we learned something about human behavior through case studies like these. And perhaps even more extreme, here we have Dr. Walter Friedman, who back in 1930s to mid 60s, he'd go around to various hospitals and perform frontal lobotomies. This was before drugs like Thorazine were around, and is thought to cure problems such as suicidal behavior, hallucinations, severe headaches, incurably mentally ill people. That what he would do is go and take in the upper left a low electroshock device for some local anesthesia around your orbit. Then he would take this little ice pick device here, put it up in the orbital frontal region. And here is one of his patients, Dr. Howard Doley, and showing an image of the frontal lobotomy done here. And this is a link to an NPR study with this guy telling his life now that he survived a frontal lobotomy with Dr. Friedman here. Anyway, here in our state of West Virginia, he did about 200 plus cases and did as many as 25 lobotomies in one day. For those burgeoning neurosurgeons out there, that's a lot of surgeries in one day. But we don't do frontal lobotomies much anymore, so we'll leave it there. All right, so I will end on that note.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.